Hi, my name is Melinda Skirvin, and I'm here to speak to you today about evidence-based practice and falls in the long-term care setting. I would ask you to please pause this presentation right now and complete the pretest that's been sent out to you. Evidence-based practice is a problem-solving approach to clinical decision-making within a healthcare organization. It integrates the best available scientific evidence with the best available experimental evidence and uses critical thinking in its application of that evidence. Falls are a huge problem in long-term care. I know all of us struggle with this from time to time. We're always trying to find out the reason why somebody's falling, and we're trying to prevent these falls, and usually not too successfully. 50% of patients fall in long-term care setting every year, and 10% of those suffer serious injury. That is huge. 1,800 nursing home patients die every year as a result of those falls. And nursing homes have about 2 falls per bed per year. 60% of all falls occur at the bedside, and falls cost Canadians $2.8 billion annually. Can you imagine what we must be spending here in the United States on falls in long-term care? There are some common causes for falls. There are confusion and agitation. A lot of times if somebody's confused or agitated, they're not thinking rationally or safely, and they attempt to get up and do things that they are not able to do anymore. Boredom is a common cause. I know in meetings when I'm bored, sometimes I just want to get up and walk around or stand. And that's clearly what's happening sometimes in our patients. The need to use the bathroom is a very common cause for falls. A lot of times they'll try to get up on their own, or sometimes they've had an accident and they're trying to get up to get cleaned. Pain can be a cause for falls. If somebody's in pain, they may try to get up to remove the pain. Sometimes they're attempting to do something unsafe, like pick something up off the floor. A lot of times somebody might be reaching for something on the floor, and they'll bend forward in their chair, topple them over, and then sometimes the chair will actually land on top of them. Sometimes it's just the need to move or exercise. I know I've been traveling a lot recently, and sitting on the airplane for those extended periods of time, I often think about our patients and how they must feel. And sometimes I just want to get up. I just want to stand for a second or walk up and down the aisle. Weakness can be a contributing factor to falls. If somebody's weak and they try to get up, they're more likely to fall. And medication often has side effects that could contribute to a fall, either through confusion or dizziness. How do you address your falls in your community? Do you use an alarm? How about a restorative or toileting program? I've heard this one a lot. Do you move them closer to the nurse's station? Sometimes you even park them in front of the nurse's station, which is one of my pet peeves. Do you review their medications to see if something might be contributing to their falls? Do you assess them for pain prior to the fall, not afterwards? And do you try involving them in a recreation program or an activities program? Sometimes that helps with the boredom and also gives another set of eyes to monitor them. Research shows that alarms are one of the first approaches, but probably one of the least effective approaches. I know I started my nursing career about 30 years ago in long-term care, and it was right in the throes of the Omnibus Reconciliation Act of 1987, and it involved the removal of physical restraints. And as a new nurse, I didn't know any different. I thought that's just the way it was. I wasn't privy to all of the history with the restraints, and it was no big deal to me, but I can remember some of the seasoned nurses complaining and thinking that the patients would be falling and hurting themselves, and they didn't know how they were going to take care of everybody. But restraints clearly had some negative repercussions concussions. It affected people's dignity. It affected their physical well-being, and actually there were more injuries than there were injuries from the use of restraints than from when they took the restraints away. Sure enough, we got through it, and there were not more falls. There were actually less falls and less injuries. However, one of the things that came out of that act was the use of alarms, of fall alarms. And fall alarms have recently been considered a restraint on the minimum data set, and are something that evidence is showing is maybe not a good approach and not a good thing to use in most cases. Alarm fatigue is one of the things that comes from the use of alarms. Sometimes in upwards of 50% of all nursing home patients will have an alarm on. And can you imagine even just half of those alarms going off at any given time can cause alarm fatigue and cause you not to pay attention to the alarm going off. It's a cause for agitation, not only with the patients, but also with the staff. There's a decrease of mobility because oftentimes when somebody does stand up, when they have an alarm on, somebody will say, sit down, or get back in bed. And or they hear the alarm go off and they automatically just sit back down and they stop being mobile. There's no difference in the number of falls with the removal, and sometimes an improvement in the number of falls with the removal of an alarm. There's a loss of dignity with alarm. Who wants to, have an alarm go off, which has a negative connotation every time you move? There's an increased pressure. There's an increase in pressure areas, and also an increase in incontinence, which are two things that happened with the restraints as well. And believe it or not, there's less oversight from the staff because they have an alarm on. I don't need to go in and check on them. The alarm will go off and that'll tell me, right? No. Research actually shows an interdisciplinary approach is the most effective approach. So it's not just one approach. It's not just an alarm. It's not just one thing, but it's a multitude of things, and it's involving the whole team and even the family members of the patient, as well as the patient themselves. I reviewed many articles, and one of the articles was a randomized controlled study in the Netherlands of 12 nursing homes, and they were able to significantly decrease the number of their falls using an interdisciplinary approach. One of the first things to do is assess for behaviors and fall risks. Involve the family members. Get the history. If somebody goes for a walk, has gone for a walk every morning for the past however many years, chances are they're going to still want to go for that walk in the morning. So let's help them walk before they try to get up and walk themselves and fall. Involve the entire team. It's not all on the nurse's shoulders, and it's a much better approach to have everybody involved in the whole team. It's a lot more eyes to be able to view and watch the patient and make sure that they don't fall. View the patient as an individual. It's not cookie cutter. What my needs are going to be different than what your needs are. Use multiple approaches. The more approaches you use, the better off you're going to be. If something doesn't work, then the next thing might. Frequent rounds is key. And again, using the whole team so you have more eyes going in at more times, you're going to stop somebody before they do something unsafe or fall. Involve the patients in the recreation or activities programs, keeping them from being bored. Again, it's also having somebody else have a set of eyes on them. A toileting program is absolutely a must. Because most of the falls, or a lot of the falls, are as a result of some type of toileting issue. Assess for pain prior to any falls. Make sure that they're comfortable. They're less likely to get up and try to do something if they're comfortable. Assess medications to make sure that there are no side effects causing any issues with falls. And definitely restorative program or an exercise program. The stronger somebody is, the less likely they are to fall. And additionally, that muscle, that bulk of muscle is going to protect the bones in case they do fall. Evidence-based practice. There was a pilot test to eliminate fall alarms in nursing homes in Washington, D.C., and they had 4 nursing homes participate. And they were able to eliminate all of the alarms and actually decrease their falls. And they did that through this interdisciplinary approach. It shows a decrease in falls with an interdisciplinary approach. There's a better quality of life without the use of alarms, and there's actually less falls without the alarms than with the alarms. Go figure. Exercise is a key approach to decreasing these falls. Again, the stronger somebody is, the less likely they are to fall. And the happier they're going to be and the healthier they're going to be. And frequent rounds, very, very important. I did also notice in my husband was recently hospitalized, and he had some confusion in the hospitalization, and I noticed that they did very frequent rounds. I think they were rounding at least every hour, and it was everybody that was involved on the team. So clearly they're using this evidence-based practice in their approach to falls. Their required actions are to assess each resident or patient for fall risk and usual habits, institute an interdisciplinary approach using the whole team, institute an exercise or restorative program. No matter what, exercise is going to be helpful. Limit the use of alarms, because there is evidence that they are detrimental and not very effective in preventing falls. Conduct frequent rounds. Assess for any needs, toileting, pain medications, anything like that. And again, review medications for any medications that might cause a side effect of dizziness or confusion. And your results are going to come. Results are going to be less falls without the alarms and improved quality of life, which is so important to our seniors. You're going to have improved physical results for your patients, and you're going to have a more comprehensive approach to falls. It's not all going to be on the nurse's shoulders. It's going to be the whole team. So involve the whole team. You're going to have not only happier patients, but happier staff, which is why I included this happy nurse and this happy patient on this slide. There's going to be less injury and death from falls, and that's what we all want. We want our patients to be healthier, and we don't want these effects from these falls. And it's going to provide a calmer environment for everybody. So the question is, falls, cause for alarm, or is the alarm the cause for falls? Please complete your post-test and complete the SurveyMonkey. Thank you so much for your participation.